Hello, everyone. Thank you for joining us today for our webinar entitled 2020 Participation in the Quality Payment Program. Today's presenter is Bruce Mackey, Alterum's Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. A PDF copy of today's slides can be downloaded right now from your GoToWebinar interface. We will be keeping everyone muted during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface, and we will address it during the Q&A. Because of the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, a link to the recording of this presentation will be available soon on the events page of our website at www.qppresourcecenter.org/events. Today, Bruce will review the 2020 participation rules of the Quality Payment Program, providing general program education, as well as reviewing the notable changes in this fourth performance year. He will discuss the participation timeline, eligibility requirements, and various reporting options, notable updates to each of the 4 performance categories, as well as changes to the 2020 performance threshold and subsequent payment adjustments. From there, he'll finish with an overview of alternative payment models and their effect on your program participation. Following the presentation, with any time remaining, Bruce will answer any questions posed by the attendees. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining me today to go through the 2020 participation rules for the Quality Payment Program. Kind of a change of environment for all of us, so I appreciate you all still joining me today. We've got a fair number of folks on the line. I am, for the first time, broadcasting a webinar from my own home office, so hopefully the technology is working just fine and everyone can hear me and all that. As you can see from the agenda on your screen now, we have a tremendous amount of information to share with you today. I will hopefully stay on track and not veer too much. Any of you that have joined me on past webinars know that I have a lot of information to share and never enough time. So with that, why don't we dive right in, and certainly send me any questions that you have. If I have time, I'll answer them live. If not, you will still get an answer from me directly via email. So here today, we're talking about the Quality Payment Program. Of course, this came to us through the MACRA legislation several years ago. It implemented this new program called the Quality Payment Program. Overall, it was designed to repeal the sustainable growth rate, or SGR formula. And overall, what it's doing is getting us away from fee-for-service payments. It was kind of long overdue to shift into a new framework for rewarding clinicians for value over volume, and that's what this brings to us. We have the 2 different kind of main participation tracks that you can participate in. We have the MIPS track, the Merit-Based Incentive Payment System, and then the Advanced APMs track. Depending on which of those buckets you're in, the program changes significantly, as do the financial aspects of it. But really, there's sort of a third path here as well that I kind of want to make you aware of. It's kind of little understood, but really the way I see it, there's this MIPS APMs track as well, and it sort of bridges the gap between the MIPS track and the Advanced APMs track. And I'll talk about that later on in the slide deck when we get to that portion of it, when we're talking about the Advanced APMs. But to me, there's sort of these 3 tracks, not the 2 tracks that CMS talks about, because of how the MIPS APMs, which constitute the vast majority of the ACOs out there, kind of how the program changes for them. So we'll start off talking about the MIPS track. It's the Merit-Based Incentive Payment System. It took multiple legacy Part B programs and kind of combined them all into a single program. It took the Medicare EHR Incentive Program, otherwise known as Meaningful Use. That's not the Medicaid Meaningful Use Program, by the way, just the Medicare Meaningful Use Program. The PQRS program, the Value-Based Payment Modifier, kind of put them into a blender and gave us this new program called MIPS. Within MIPS, we've got 4 different performance categories that you're going to participate in. or you can participate in. We have the quality performance category, the cost performance category, something called promoting interoperability, which is really just what's left over from the Medicare Meaningful Use program, and then improvement activities. And really through the whole thing, what you're trying to build overall is the best MIPS final score that you can. A 100 final score, or 100%, is the best you can possibly do in the program. And each one of those different MIPS performance categories contributes a certain weight to that MIPS final score. We have seen these shift over time, and the weights on your screen now are the same ones that we had in 2019. They did not make any changes to the weights for 2020. So the quality category is 45% of that score, cost is 15, improvement activities is 15, and promoting interoperability is 25%. So all the points within each of those categories then get determined and kind of rolled up, added together to create that MIPS final score. Then that final score is compared to the annually set MIPS performance threshold to determine if the participant or group receives a positive, negative, or neutral payment adjustment. This year in 2020, as expected, we saw that minimum performance threshold increase. In 2019, it was 30 points. This year, it is 45. So we've got to continue to get better and better in this program to ensure that you are at the very least staying over that MIPS performance threshold so that you do not take a pay cut. We'll talk about the MIPS timeline here. So this is kind of how it is normal on the books. I've got a little star there because we do see some potential changes coming due to the COVID-19 crisis that we're all dealing with right now. There will be more to come on this as we work with CMS to learn more about what they're thinking and how they're going to change things. So on the books, the regular rules would dictate that we are in the performance period that started on January 1st of 2020, and it goes through the end of the year. There is some information coming from CMS that, again, I think there's some conflicting information. There's some questions on this that I myself have for CMS as well. So more to come as they kind of finalize these rules, but there is some information out there that would suggest that CMS is not going to use the first 6 months of 2020 in any of their quality improvement programs. So it could be a 6-month performance period this year, but more to come on that as CMS kind of finalizes what they're doing in the quality payment program. That's why that little star is there. But in the normal rules anyway, we're in that performance period until the end of the year. After 2021 hits us, we've got about 3 months to get our data submitted. CMS then provides us some performance feedback, and that we get usually around mid-year. And then, as is always the case, there's always a 2-year lag between the performance year and the payment year with all of CMS's programs. So the work we do now in 2020 will affect your 2022 payments. So next we'll talk about the program eligibility criteria and reporting options. We did not see any changes from 2019 to 2020 on who is eligible, the different clinician types that are eligible for this. We refer to them in this program as eligible clinicians, or ECs. So the same list of clinicians that were eligible in 2019 are the same ones that are eligible in 2020. Those folks are on your screen right now. We also didn't see any changes to the low volume threshold from last year to this year. So that low volume threshold, once you determine that you are a MIPS eligible clinician type, we then look at your Medicare volume to determine whether your participation is mandatory or is it perhaps voluntary. And I'll talk about those options in just a moment as well. But looking at that low volume threshold for 2020, it did not change from last year. To find your participation mandatory in the program, you have to bill more than $90,000 a year in allowed charges, and you have to furnish covered professional services to more than 200 Medicare beneficiaries, and you have to provide more than 200 covered professional services to those Medicare beneficiaries. If all three of those conditions are true for you as an individual clinician, you would find your participation in this program to be mandatory, meaning if you do not submit data, you are absolutely going to take a payment penalty. There's a couple of different ways to check your eligibility for you or your group. You could look at that link right there on your screen. You could also alternatively log in to the QPP data submission portal. That's also at that same website, where the one on your screen right now is a place where you can put in a single NPI, provider NPI, and it would give you their eligibility. If you log in, you can look at your eligibility through your login screen, and that's going to show you all of the clinicians in your tax ID all at one time. So to be included in MIPS then, the clinician or group has to exceed all three of these criteria. And a particular note at the bottom down there, for ACO participants, for instance, anyone participating in what would be deemed a MIPS APM, the low volume threshold is determined at the ACO level. So you don't necessarily look at your own individual eligibility at that point, much like a TIN group would look at their eligibility together. If you're in any type of ACO, your eligibility is determined at the ACO level. So it is highly unlikely that any ACO out there would not exceed the low volume threshold, because they're adding all of that Medicare volume for every participant of the ACO together to overcome that low volume threshold. So as you can imagine, that's very easy to do when you've got an entire ACO's worth of clinicians together. So what happens if the clinician or group is excluded, meaning they do not overcome all three elements of that low volume threshold, but they still want to participate in MIPS? There's a couple of different options here. The first one on your screen, voluntarily participate, we have had as an option since the beginning of the program. You could still submit data to CMS and they would give you some performance feedback, but there is no MIPS payment adjustment regardless of performance. So it doesn't matter if you're doing really well or really poorly. If you voluntarily participate, none of that is going to affect your Medicare payments. You could, however, opt in. It was something that was new to us in 2019. It is again an option in 2020. That if you are a MIPS eligible clinician type and you meet or exceed at least one of those three low volume threshold criteria we just discussed, you may opt in to MIPS participation. If you opt in, you're going to be subject to all of the MIPS program rules and the financial part of it. So you would not want to opt in if you didn't have good data. However, if you do overcome one or two of those low volume criteria and you can generate really good MIPS data, it might be a good idea to opt in, because you are going to, at that point, be treated just like a clinician who finds their participation to be mandatory in the program. Once you do opt in, you cannot reverse that decision for that single program year. So again, you want to really, before you opt in, you want to take a look at that data to determine whether it makes sense for you to do so or not. There's a great link there if you grab the slide deck, which again is available right now through the handouts portion of your GoToWebinar interface. I've got a lot of links built into these slides as well to get you to some good additional information. We also did not see any changes in the reporting options. So from last year to this year, there are three different ways that you can participate in the program. Clinicians can participate as an individual clinician. In that way, each NPI and tax ID combination is seen as a separate program entity. So if you are a clinician who is working for multiple organizations, what you do in each one of those organizations is treated differently. You would get a different MIPS final score, and subsequent payment adjustments would be different at each one of those organizations. You can also participate as a group. So in that way, everybody who is within the same tax ID number would consolidate all of their data and send a single data set to CMS. In that way, all of the folks in the group would get the same MIPS final score and the same subsequent reimbursement rate. This is a good way to kind of sort of opt in to the program as well. If you have, let's say, 5 clinicians and on their own, none of them overcome that low volume threshold, chances are that as a group, when you add all of that, the Medicare volume together, the group would be able to overcome that low volume threshold. Note, however, that group participation is never mandatory, at least a TIN group anyway. So it is only mandatory if the individual clinician overcomes that low volume threshold. Group participation is always voluntary. However, note that if you are in any type of ACO, as I already mentioned, you are locked into that group participation. You cannot participate at the individual level if you're in any type of ACO. You are locked in to participating as a group, and it's not just your own TIN group. You are in that super group that encompasses all of those ACO participants. There is also the third option, which is a virtual group participation. Think of a virtual group as sort of like a mini ACO. That's the best way I can describe it. In much the same way that an ACO is pulling clinicians from multiple tax IDs together to participate as this big super group, a virtual group sort of does the same thing. It is made up of solo practitioners and very small groups of 10 or fewer eligible clinicians who come together virtually to participate in MIPS together. There is a whole process involved to elect to participate as a virtual group. It would be too late to do that for 2020 at this point if you had not already formed your virtual group. The virtual group election process, if you were looking to form a virtual group, would open up in the 4th quarter of this year for any virtual groups looking to participate together in 2021. So a question that I field a lot then is, does it make sense to report as a group or as individual clinicians? There's really, for the most part, no easy way to answer that. You kind of have to take it on a case-by-case basis. But overall, it kind of makes sense to do both ways. And the reason for that is that if CMS receives group data as well as individual data on any one clinician, they are going to award that clinician with the better of those 2 scores. So that is actually a really good strategy to leverage, because with that in mind, the best strategy is to always group report unless the group score is below that minimum performance threshold. Then you absolutely don't want to do that. If your group score is below that minimum threshold, which again in 2020 is 45 points. But if your group can get over that 45 points, probably makes sense to go ahead and group report. And then if any eligible clinician within that group is eligible to report individually, meaning that individual clinician overcomes that low volume threshold on their own, and his or her individual MIPS final score is better than the group average, also submit that clinician's individual data to CMS. That overall is the best strategy, because if by doing that, a lower performer's scores in the group are raised by the higher group average, and then higher performers are not negatively affected by the lower performers, because CMS is going to give those ECs their better individual scores instead of that lower group score. Next, we'll talk about some changes across the categories for 2020. We did not see significant changes, but there's some really good ones here. I think CMS continues to kind of tweak the program. They look at what's not working and look for ways to kind of shore it up a little bit and make it work a little bit better. So we definitely do see some changes, although they are not significant from 2019 to 2020. Here's sort of an overview of the changes. In the quality category, they've increased data completeness threshold to 70%. And note that I'm going to talk about all of these in a little more detail as we get deeper into this deck as well. They're continuing to kind of get rid of some of the lower performing quality measures. There's some interesting changes to a couple of the benchmarks and how they're going to score a couple of the measures, and I'll talk about that. We've also added some new specialty measure sets. On the cost category side, we have 10 new episode-based measures this year. They've also made some good changes to the two kind of main overarching cost measures, the MSPB and the TPCC, and I'll talk about that. Really, it comes down to some changes in the patient attribution that I think were definitely needed. That'll help kind of clean up those measures that have been kind of working sort of wonky for some folks up to this point. Improvement activities had a couple of changes. They've increased the participation threshold for a group reporting from a single clinician to 50% of the clinicians. I'll talk about that a little bit more. And in the PI category, we've seen a couple of changes where they dropped one of the bonus measures that we saw in 2019, and they've also reduced the threshold for a group to be considered hospital-based, which is another good change I'll talk about. The performance periods on the books, we did not see any changes in that from last year to this year. So again, within each one of those performance categories, you must submit a certain amount of data over a certain time frame. So no changes from 2019 to 2020. But again, you'll see those 2 stars next to quality and cost because we're kind of waiting for more firm direction from CMS. I think they're going to make some adjustments in 2020 here. There's some kind of sort of conflicting information that they sent out across the country on Sunday afternoon that would lead us to believe they are going to shrink the performance periods for 2020 on quality and cost down to 6 months. They're only going to use from July to December. But don't write that in stone quite yet. Again, it's sort of conflicting information, but I did put those stars there. So as of right now, we're 12 months of quality, 12 months of cost, which could shrink down to 6 months once CMS kind of firms up those new rules for 2020. And then improvement activities is 90 days, and promoting interoperability is also that minimum 90 days. Again, both of those are minimum 90 days. You can certainly report longer reporting periods or performance periods for both of those categories if it makes sense to do so. All right, let's take a little deeper dive into each one of the performance categories now. Starting off with the quality performance category, since it's worth the most, it is worth 45% of your MIPS final score. If you're new to the MIPS program, and even if you're not, I would suggest taking a look at the quick start guides that CMS has put out for each one of the performance categories this year. I think they've really done a nice job here. In prior years, they were using something called fact sheets that ended up being, up to 20 pages of just paragraph after paragraph of text to try and give you the bird's eye view, which was sort of overwhelming. I think they've really done a good job of developing these quick start guides this year. I would highly recommend clicking on those. It's more of a sort of a slide deck resource that gives you kind of the basics for each one of these categories that I think are some really good resources. So I recommend clicking on those quick start guides that are in the slide deck here. We've got 218 quality measures in 2020. So again, they have continued to get rid of quality measures. So I caution you, if you are looking to reuse your quality measures from last year to this year, just make sure that they're all still available in 2020, because we are continuing to see them narrow the scope of quality measures. We started out with about 270 some, so we're down to 218 this year. So just like last year, you have to select and report on a minimum of 6 individual quality measures if you're going to fully participate in the program or in this particular category. 1 must be an outcome measure or a high priority measure if an outcome is not available. If fewer than 6 measures are clinically applicable to you, you can report on each one that is applicable. If CMS agrees with you, and I caution you to click on the link there for the EMA process, that is an important consideration. But if CMS agrees that for your particular specialty, there are fewer than 6 that are clinically applicable, the category denominator is going to be appropriately lowered. So instead of being out of 60 points, it would be, let's say you only had 3 clinically relevant measures out of the 218. It would lower your denominator so that you weren't negatively affected by that. But again, CMS has to agree that there were fewer than 6 clinically applicable to you. You can also select a specialty measure specific set. They have given us quite a few of those now. And all of those specialty-specific measure sets have already gone through that EMA process. So if you choose to report in a specialty-specific measure set and it already has fewer than 6 measures in it, which there are a number of them that you'll find are like that, the denominator is already going to be appropriately lowered because CMS already agrees that that particular specialty has fewer than 6 clinically relevant measures. There are bonus points available again. No changes here from last year. They want your data. They want your measures. So they're going to incentivize you to sort of over-report measures by giving you some bonus points. You can get 2 bonus points for each additional outcome or patient experience measure. You get 1 point for other high priority measures. You get an additional point for each one of your 6 measures that is submitted using something called end-to-end electronic reporting. There's a lot of different ways that you can get your data to CMS, and I'll talk about that because it makes a humongous difference in your quality score. But if it is one of the reporting methods that is deemed end-to-end electronic, you're going to get an additional bonus point for each one of those. So end-to-end electronic means that there's no human intervention there. So claims-based reporting is not end-to-end electronic reporting. However, if your EHR is reporting for you, or you are getting what's called a QRDA or a JSON file, that quality data file from your EHR and submitting it to CMS, that would be end-to-end electronic, and they would give you those bonus points for that. Similar to last year, we also have the small practice bonus again this year of 6 points. So if you submit any quality data to CMS, and you are in a small practice, which is defined as 15 or fewer Medicare billing clinicians, they're automatically going to add an additional 6 points to your quality category score. And bonus points are capped at an additional 10% of your denominator, whatever that is. For most of you, it's going to be 60 to 70. So you can only get an additional 10% above that. This concept of data completeness is getting increasingly more important to consider as well. You'll hear people refer to this as cherry picking, but it is something that has been with us since the beginning of the program. So with data completeness, CMS checks to see if you or your group have submitted data on a minimum percentage of patients that meet a reported quality measures denominator criteria. So it has increased from 60% last year to 70% this year. So you have to make sure that you are reporting that minimum data set. So look at one of those quality measures and look at the denominator criteria. You have to ensure that you are reporting on at least 70% of those of patients to which that quality measure is relevant. If you are reporting via your EHR using those ECQMs, those electronic clinical quality measures, data completeness is always 100%. So there's no way to tell your EHR to not apply the quality measure to certain patients. But for some, like let's say claims-based measures, if you're reporting through claims, you might miss putting those G codes or those quality data codes on your claims. If you do that for too many of those patients, you're going to fall below that data completeness threshold, and then you're not going to earn the points based off of your performance on that measure. So measures that do not meet data completeness this year are going to earn 0 points. So it's an important consideration. However, if you are in a small practice, 15 or fewer Medicare billing clinicians, it's going to bottom out at 3 points. You're never going to fall below that 3-point threshold. So even if you do miss that data completeness threshold as a small practice, you're still going to receive 3 points instead of 0 for the large practices. I already mentioned how they're continuing to get rid of kind of underperforming low bar standard of care and process measures. So we're going to continue to see this happen over time. They're going to continue to whittle the landscape down. It's sort of an overwhelming number of quality measures. A lot of them are just not performing well. So CMS is going through the meaningful measures process to whittle that down. I think year to year, we'll see the landscape of quality measures continue to shrink. They did, however, add several new specialty measure sets, which you see on your screen now. So this is an interesting change that we're seeing this year. I suspect we might see this expand to include other quality measures in the future, but CMS has made some changes to avoid the potential for inappropriate treatment. Through working with these quality measures over time, they have determined that a couple of the measures with two of the different reporting options, potentially incentivizing patients or providers, I mean, to prescribe treatments that are kind of inappropriate for patients. The issue with these two quality measures, the two that it affects right now, are MIPS number 1 and MIPS 236, the main diabetes hemoglobin A1C measure, and the kind of main controlling high blood pressure measure. Many of you are using these, NQF 59 and NQF 18. Through claims-based reporting and through registry reporting, they have determined that there are not enough sort of exclusions or exceptions built into these. So they are afraid that having these performance thresholds built in are potentially incentivizing clinicians to sort of over-medicate their patients, because there are not enough exceptions or exclusions built into these quality measures to allow clinicians to remove patients from the denominator. So for these two quality measures for this year, for just claims-based reporting and registry reporting, they are not going to compare your performance against the measure's benchmark. They are going to what's called flat percentage benchmarks. So they're going to ignore the performance benchmark that is being used for all the other quality measures and all the other submission methods. And they're really just going to give you points based on your performance, not compared to that benchmark. So let's say you find yourself in the 5th decile. Normally, that performance would be compared against the benchmark, and that would determine how many points you get. Now it's sort of straight percentile benchmarks, meaning if your performance rate is somewhere in the 80% range, you're just going to get 8-point-something points for it instead. So again, I think we'll see this expand over time to include other quality measures, but stay tuned on that. So I have a lot to say here. This is where I tend to go off the rails and spend too much time, but it's really important to, how the quality measures that you choose and how you report them to CMS really makes a tremendous difference in your MIPS performance category, and then subsequently that MIPS final score. Picking your quality measures is very difficult. You'll want to pick ones that are clinically relevant if you can. That's not always easy to do. You might look at what your practice goals are, align your quality measures to those overall practice goals or your patient goals so that changes you make throughout the practice are going to help boost your quality score. For a lot of you, finding 6 clinically relevant quality measures in the 218 that are available to us this year is really difficult. You might think about looking at some of the registries that are catering to your particular specialty. There is this concept of a MIPS CQM out there. What that means is these specialty societies or registries are basically inventing their own quality measures. And there's some really good ones out there, and they cater to those specialties. They are then going to CMS and petitioning CMS to say, hey, look, we've got this great quality measure. Can our clinicians use this in the MIPS program? CMS looks at that measure, says, yeah, that's a good measure, good job. We're going to stamp this as a MIPS CQM, meaning that these registries have their own custom measures now that are often perform better or are more clinically relevant to your particular specialty. So if you are having trouble finding good quality measures in the normal list of CQMs available, you might look at some of the registries that are catering to your specialty society, and they might have some kind of custom measures that you can use in the MIPS program. So another huge consideration, if you are relying on eCQMs, the ones that are built right into your EHR, Unfortunately, as it stands today, I would advise you against just outright trusting the data coming out of your EHR. Just because your EHR is certified to offer a particular quality measure, it unfortunately does not mean that EHR is calculating it correctly. And I know how silly that sounds, but that is the truth. The EHRs are doing the best they can. It's hard to program these measures. They're trying to build it right, but unfortunately, mistakes are still being made. They're cleaning it up. We certainly see fewer and fewer vendors having issues with these quality measures. But unfortunately, you can't just take the data coming out of your EHR and trust it at face value, because some of these vendors still have them programmed incorrectly. So you've got to really do a deep dive into the data coming out of your EHR and to ensure that your EHR is calculating it correctly. Your EHR might indicate you have low quality measure scores, but you might be doing everything right, and it's your EHR that has it wrong. I would advise you all to take a deep dive into the numerators and denominators coming out of your ECQMs and try and figure out, look at that denominators, look at the patients that are being captured in that denominator, and then look at the patients that are missing in the numerator, and kind of look to see if is that right, or is it in fact an issue with your vendor where they have not built that ECQM correctly. These electronic clinical quality measures also don't necessarily work right out of the box. Some of them require some practice level configuration for them to work properly. You might have to link some codes in the back, some link codes or something like that. So you've got to do some measure mapping in order for the EHR to calculate it correctly. So you want to make sure that you're configured properly as well. Hopefully your EHR can assist you with that, your EHR vendor. Data entry issues, we're all human. Everybody makes mistakes, unfortunately. I guarantee your MAs are masters at trying to reduce the number of clicks, and they all build workarounds no matter how they've been trained. So there's often data entry issues as well. Each one of those ECQMs is looking at specific structured data fields to be recorded in specific places. And if your staff are not utilizing the EHR the way they should be, what would look like a low quality score is really just a data entry issue. So again, doing that deep dive into those quality measures is going to help you to uncover when you have what is not really a quality of care issue. It's actually a data entry issue. And it's really only after you've gone through the vendor issues, configuration issues, and data entry issues that you can begin to trust that data that's coming out of your EHR. The data submission type also really matters. I've kind of alluded to this. There's different ways to get your data to CMS, your quality data, claims-based, registry, ECQM reporting, and each one of those methods can net a very different cost category score. And I'll talk about why that is on the next slide. And then you want to, if you can, avoid topped-out measures and capped at 7 points measures. So a topped-out measure is one where really the benchmark is really high, meaning everybody who's reporting on that quality measure is doing really well. So there's very little difference between the highest and lowest performers in that measure. It gets classified as a topped-out measure. And then if it's topped out long enough, it is also being capped. So each one of these quality measures, you can earn anywhere from 0 to 10 points on a regular quality measure. But if it's significantly topped out, meaning it's been topped out for multiple years, CMS is now capping those at 7 points as well. So you can't earn 10 points for perfect performance. That perfect performance on that quality measure is only going to net you 7 points instead. So obviously that's going to undercut your overall quality category score as well. So back to that submission type having a lot to do or having a significant, making a significant difference, it really comes down to the benchmarks, okay? So your performance on any one quality measure is compared against the benchmark's the quality measure's benchmark. Then depending on how your performance compares to the benchmark, that determines the number of points that you get. However, each one of the submission methods gets its own benchmark, right? Because we see widely ranging performance rates depending on how that data is being routed to CMS. Here's a rudimentary example here. I know there's a lot of numbers here, but follow the colors with me. So here we have a performance rate of 62 on a particular quality measure. We're looking at measure ID 110. These are old benchmarks, so don't necessarily look at the benchmarks. Just I have this here just kind of give you the concept of why this matters. So here we have the actual mathematical formula on what that 62 means. But really just look here. So 62 for claims-based reporting on this quality measure is going to put you somewhere in decile 5, meaning you're going to get 5 point something. As it turns out, against that particular benchmark, a performance rate of 62 submitted through claims-based reporting you 5.96 points. That exact same measure can be reported through your EHR as well, and that gets a different benchmark. So that performance rate of 62, looking at the EHR benchmarks, is going to get you somewhere in the 8-point range. In this instance, it would net you 8.9 points. So nothing has changed with your quality of care. The only thing that has changed is that you've gone from submitting that data to CMS via your claims versus your EHR. It's going to net you about 3 more points in this example. And then registry is also an option for this measure, which also has a different benchmark from the other two. And if you submitted that same performance rate of 62% through a registry, it's going to get you somewhere in the middle at 6 points. In this example, it's 6.64. So you can see the exact same quality of care, the exact same performance rate can have a vastly different number of points awarded to it. So multiply that 6 times over. You can begin to see how choosing the right submission type can have a profound effect on your quality category score. Topped-out measures, again, as I already talked about, you want to try to avoid topped-out measures if you can. It's not always easy. A lot of the quality measures are unfortunately topped out. And then, as I mentioned, several of the measures are topped out and capped at 7 points, so you really want to avoid those if you can. But it gets a little deeper than that. Here's why you want to avoid the ones that are not capped but are still topped out. If you look at my example here on the top, we have a few different quality measures that are topped out but are not capped. This is a screenshot from the benchmarks file that you can get from the QPP CMS website. If you go to the resource library and search for quality measure benchmarks, you're going to find an Excel file, and that's what these are taken from. It kind of shows you all of the information across all of the measures across every single submission type or collection type, and gives you the different benchmarks. It also gives you their topped out status. So we have measures here that are topped out but not yet capped. But look at what happens here. So we start to lose decile options, meaning you cannot get points here in these missing deciles. So on this particular one at the top, a 99.99 performance rate, so near perfection. You are doing a fantastic job, but you're just not quite at 100%. It's still only going to net you about 6.9 points for that. You cannot get 7, 8, or 9 points. It's not until you have perfect performance at 100% that you can get the full 10 points there. So any small blip, one bad patient outcome could significantly hurt you. Look at this one. Near perfection is still only going to get you 4.9 points. And if you cannot get anywhere in these deciles, you've got to get that perfect performance. So watch out for those topped out measures. And then it gets a little harder than that. So some of them are not topped out yet, meaning they haven't kind of got that designation of being topped out, but we're already starting to see some scoring options that are limited. Here we have a few different options where they're not topped out, which means they're definitely not capped at 7, but we're already starting to see it top out, meaning we're already starting to miss some of those decile points. So again, even if it's not topped out, that near perfection in your performance might still net you less than those 10 points and might significantly hurt you if you multiply this 6 times over too. where you can only get into decile 6 versus decile 10 for that almost perfect performance. So it is a difficult landscape to navigate, but spending time on this can have a profound effect on your quality category score. All right, next we're going to look at the cost performance category. Again, we've got that quick start guide there. It's worth 15%. It is mandated to increase to be 30% of that final score by 2022. There's no reporting requirement, so CMS is pulling everything you need off your administrative claims here. We've got a total of 20 different quality or cost measures that are applicable now in this performance year. We have the MSPB and the TPCC, the total per capita cost measure. And now we have 18 episode-based measures. We only had 8 of those working for us in 2019, so now we're up to 18. They've added 10 additional ones. So in order to be scored on any one of those cost measures, the ECR group must have enough attributed cases to meet or exceed the case minimum for that particular cost measure. Usually that is 20 particular cases that you have to have in order to be scored in any one of those cost measures. So no clinician that I'm aware of is scored against all 20 of those. Usually 1 or 2, maybe 3, maybe 5 of those are applicable to a clinician. Sometimes none of them are applicable to a clinician. If any one of those 20 cost measures can be applied to a particular clinician, whatever does apply is going to be used to calculate the entire cost category score. And if no cost measures can be applied to the EC or the group, then we'll see some reweighting where the cost category will be shifted down to 0% of the MIPS final score. 15% will get added to the quality category, making the quality category be worth 60% as opposed to 45%. Again, we did see some good changes here in the cost category, in the measures that they are using here, particularly with the TPCC and the MSPB. They've actually created a brand new MSPB measure called MSPBC, or MSPB Clinician. And again, a lot of the changes come down to the patient attribution. So in prior years, we've seen CMS do some kind of wonky things with attributing patients to clinicians that make no sense whatsoever. So CMS has listened, they understand the issues, and have tried to clean these cost category measures up a little bit by fixing some of the attribution problems that we've seen in prior years. So we're thinking this year they're going to work a lot better for clinicians. They're really going to make a lot more sense. Here we've got a couple of definitions for the 2 main ones, the MSPB and the TPCC. I'm not going to get too deep into what these mean, just in the interest of time. This is the list of 18 episode-based measures that are being used this year. I would urge you, if you want some additional information on these, to click that resource down at the bottom. It will give you a wealth of information on each one of these cost category measures. Before I get into the next 2 performance categories, I'm going to pause and talk about facility-based scoring. This is something we saw them bring in 2019. It is again an option in 2020. I think this is a fantastic option that's really going to help some of these facility-based clinicians. If you are a hospital-based clinician, it has routinely been sort of difficult for some of these clinicians to get at their MIPS data because they are hospital-based. They're doing the majority of their charting in the hospital system, which may be completely inaccessible to you in terms of reporting that data to CMS. So CMS last year instituted this facility-based scoring for quality and cost categories. I've got the definition of what it means to be a facility-based clinician. It's not quite the same as a hospital-based, but it's very similar definition. I've got those definitions there on the screen of what it means to be a facility-based clinician or a facility-based group. So once you're deemed facility-based, you're going to be attributed to the hospital where that clinician or group is seeing the most patients. And really what it means is if you're facility-based and you can be attributed to a hospital, is going to attempt to calculate your quality and cost category scores off of the hospital's VBP score. Many of the Medicare hospitals are participating in the hospital value-based purchasing program, and it's sort of the hospital version of MIPS, sort of. Very different, of course, but they are kind of scoring these hospitals on quality and cost. And so they are going to use that hospital VBP score to award these facility-based clinicians with the quality and cost category scores that then feed into their MIPS score, if that makes sense. So some hospitals do not receive a total performance score in a given year for the hospital VBP. So if that's the case, they wouldn't be able to award you or to be able to use the hospital's VBP score to calculate yours. And note, this is very important, given the timing of the data and the scores for the VBP program relative to the quality payment program, you won't discover that your facility can't be scored until it's too late for you to submit your own practice level data. So my advice to you, to always also submit your own quality category data if you can. I know for some of you that are facility-based, that's impossible because 99% of what you're doing is locked into the hospital's EHR. But if you can submit your own quality category data, even if you are facility-based and you're hoping to fall back on the hospital's VBP score, don't just rely on that, because if something goes wrong with the hospital in their purchasing program, you won't find out that happened until it's too late for you to submit your own data, and then you would be out there without any quality data whatsoever. So CMS is going to automatically apply facility-based measurement to any MIPS eligible clinician who they can score under this new scoring method and who would benefit from it. There's nothing that you would have to submit as an individual clinician to have this happen to you as a facility-based provider. But if you're a group and you would like to be scored as a facility-based group, you've got to alert CMS in some way, shape, or form that you want to participate at the group level. You would do that by submitting group level improvement activity or promoting interoperability category data. That signifies to CMS that you're participating at the group level. And then if they can use facility-based scoring at the group level, they're going to do that for you. And also, I would suggest, just like what we talked about earlier about group versus individual reporting and how it often makes sense to do both, I would suggest here, even if you are falling back on facility-based scoring, that if you can submit your own practice level data, that you do that as well, because CMS sort of does the same thing here. If they're going to automatically try to apply facility-based scoring to you, but if you also submit your own quality performance category data, CMS is going to score the hospital data and your own submitted data, and then they're going to award you with the better of the two. So just because you can be facility-based scored doesn't mean you necessarily should just rely on that. I would suggest also submitting your own practice level data, and then whichever one is going to net you the better MIPS final score, CMS is going to use that data. And I've got a facility-based quick start guide link there for you to learn more about that. Okay, on to the next two performance categories. We have improvement activities. Again, there's that quick start guide. It's worth 15% of your MIPS final score. We did see, I think we had 118 improvement activities in 2019. So we've lost some of them. There's 105 this year. So again, make sure that if you're going to reuse your improvement activities from last year to this year, which is totally allowed, just make sure that it's still one of the 105 that are approved for use in 2020. Each one of those activities is weighted at 10 points if it's medium weight and 20 points if it's high weight. You max out in this category when you hit 40 points within the category. So if you earn 40 points in the improvement activities category, that's going to net you the full 15 points in your MIPS final score. Unless you are in a small practice, each one of the category weights are doubled, meaning a medium weight activity is worth 20 points and a high weight activity is worth 40 points. So as a small practice clinician, or if you're non-patient facing, or if you're practicing in an HPSA area, a single high weight activity gets you the full 40 points and you'd max out in that category. There are they have decreased, they've gotten rid of some of the activities. They've also added a couple. The drug cost transparency measure is new, and there is also a new measure, an improvement activity related to the MACRA patient relationship codes, or PRCs. If you're not already aware, I would suggest you take a look at that, at the patient relationship codes that are coming at us. We are in a voluntary reporting period for PRCs right now. It's going to eventually become mandatory, meaning that every single Medicare clinician is going to have to start using these PRCs sometime in the future. I don't know when it's going to happen, but they are incentivizing you to start voluntarily reporting PRCs right now by creating this new improvement activities. You can get improvement activity credit for voluntarily participating in this PRC voluntary reporting period. So again, they've made some additional changes. Some of them are modified, some are removed. And I've already talked about how while you can use the same improvement activity from one year to the next, as long as you've kept it implemented, make sure that it's still on the list and valid in 2020. I would also suggest you grab the data validation file. The link is there on your screen. This is a very valuable file. I still refer to it on a regular basis as well. It gets you some additional vital information on your improvement activities, particularly what CMS is going to recommend that you have to prove in the event of an audit that you had that improvement activity implemented. So there's sort of an honor system here in this particular category where you're just attesting to the fact that you had an improvement activity implemented. Don't lie and tell them you did something that you didn't. And then also make sure that you have that proof. You could get audited up to 6 years from now, where CMS is going to ask you to prove that that improvement activity was implemented up to 6 years ago. And so they've got some great recommendation there on what those auditors are going to be looking for. This is an important change that they made. In prior years, if you were reporting at the group level, you could attest to an improvement activity if at least one clinician within your tax ID implemented an improvement activity. That has changed now. So now it is not a single clinician. At least 50% of the clinicians in your tax ID number have to be participating or have to implement that activity in order for the whole group to get credit for that activity. It does not have to be the same 90-day performance period, so you could each have it implemented for a different 90 days within the year, but it does have to be implemented for at least 50% of the clinicians at some point during that performance year. They also kind of cleaned up some of the questions we've had about how patient-centered medical home fits into the improvement activities category, particularly here in the state of Michigan. There have been some concerns or issues related to how the specialty side of PCMH would play into it. So this was true last year. They've just sort of formalized it and made it a little bit clearer that in the state of Michigan anyway, the Blue Cross Blue Shield PCMH program, they also have the PCMH Neighbor program. In prior years, it was sort of, we weren't really sure how that played into it. It definitely works as PCMH designation for this year, and they've kind of formalized those rules. PI category, we don't have a ton of changes. It's worth, again, 25% of your MIPS final score. You have to use 2015 edition certified technology, and then performance is based at the individual measure level, same as we saw them change last year. There are the same 4 objectives as we had in 2019. There are 7 measures in total to report on. We have the e-prescribing. There used to be 2 bonus measures tied to e-prescribing. They've removed the Verify Opioid Treatment Agreement bonus, but there are still some bonus funds available for the PDMP measure. We have health information exchange, provider to patient exchange, and public health and clinical data exchange. So if you have any questions on how those measures look for this year, I didn't see a lot of changes. It's probably still a good idea to review those, the specification sheets, and that link is at the bottom of this slide. An important consideration within the PI category is this concept of reweighting. There is automatic reweighting that is applied without any clinician action. And by reweighting, I mean that the weight for that particular category shifts over to quality. So in automatic reweighting, the PI category would be worth 0% of your MIPS final score, and it would shift over to quality, making that worth 70%. It's done automatically for nearly all of the EC clinician types. And so everyone except the MDs and DOs essentially is automatically reweighted, as are non-patient facing clinicians, hospital-based, and ASC-based clinicians. So what that means is if you are any one of those clinician types, if you have that special status, or if you're one of those EC types, CMS is not expecting PI data from you. You do not have to do anything. This reweighting happens behind the scenes automatically, but you can override it, and it often makes sense to do so. You would override it by just submitting PI data anyway. So if you are, let's say, a nurse practitioner, you don't have to submit PI data, but if you do submit PI data in this category, CMS is going to score it automatically. They're going to take that to mean that you're going to override that reweighting, and that 25% that they're automatically applying to their quality category is going to shift back over to PI for you, and you'll be scored accordingly. There's also application-based reweighting available under certain circumstances. The same thing happens, but you do have to apply for that. There is an application, or you can get sort of an automatic reweighting if you're a small practice, but you have to apply for it. The small practice reweighting of PI is not an automatic thing. You have to ask CMS to reweight you if you're a small practice. But if you do put in that application and you're a small practice, it's going to be automatically approved, just based on the fact that you have 15 or fewer Medicare billing clinicians. But that does not happen unless you apply for it. There's some other reasons there as well. The extreme and uncontrollable circumstances that could change. I think COVID-19 is going to play into that for this year as well. But again, we'll see how that all shakes out as CMS kind of finalizes our 2020 rules based on the COVID-19 crisis. The application is not available quite yet. We usually don't see this come available until around summertime, so around July or so. We're likely to see this application. I got the link there for where it will be posted when it does come live for us for this year, for 2020, and you have until the end of the year to put it in. So as long as you put it in by December 31st of this year, CMS will take a look at it. So it's an important consideration for those small practices as well. I won't spend a lot of time on this slide. This is more just a little reference for you. Many of the PI measures have exclusions built in, but you don't miss out on those points if you claim the exclusion. The points for that particular measure will just get reallocated to one of the other existing PI measures. So this just kind of tells you where those points are going to shift. So on the left-hand side, it shows you where they would shift to, and then it shows you the point distribution if you were to claim all of the measure exclusions. Essentially, it's going to put all of the points on the patient portal measure instead. This is an important consideration. I'm thankful that they did this. In prior years of the program, if you had, all of your clinicians were deemed hospital-based except one of you, and you were not a hospital-based group. So kind of group reporting when all but one of your clinicians was hospital-based meant that you didn't get that reweighting because you had that single clinician that was not deemed hospital-based when all the rest of the clinicians were within the TIN. That has changed a little bit. This is a nice change. So now a group is identified as hospital-based and eligible for that automatic reweighting when more than 75% of the NPIs in the group meet that definition of a hospital-based clinician at the individual level. So that is a great change that they made. Okay, 2020 performance thresholds. What's it all mean once you kind of stack all those points up together and to determine that MIPS final score? I already talked about the change in that performance threshold. We will see that minimum performance threshold to avoid a penalty increase from year to year. 2019, it was 30 points. 2020, it's 45 points. The exceptional performance threshold, which nets you a little bit additional incentive, also shifted from 75 points up to 85 points. And then the payment adjustment has also increased as well. It was plus or minus 7% last year, plus or minus 9% for this year. But just keep in mind that this is a budget neutral program, which by that I mean that those that are getting penalized are the ones that are paying for the incentives on the top end. But there is this concept of the scaling factor that's built into it. And as we have seen in prior years, what was in 2019 projected to be as much as a 7% increase, without COVID-19, CMS was projecting was probably going to be more like a 7% increase for a perfect score. We're not really sure how COVID-19 is going to play into it, but some of the ability to take a pass this year that they're building in right now, we just received word of that on Sunday, I think is going to significantly reduce the monies that will be available to pay out on the top end. So we'll see how that all shakes out. I can also guarantee that in 2020, nobody's going to receive a 9% boost in their Medicare reimbursement. We'll have to wait and see how the scaling factor comes into play for 2020. But you could get penalized 9%, but on the top end, I don't think anybody's going to earn a full 9% quite yet. That's going to change over time, though. There is not a huge return on investment in this program, but I would urge you all to think of it as a marathon, not a sprint. The work that you are putting into the MIPS program today is going to pay off more down the road. You want to be doing everything you can to get the best MIPS score that you can get right now, because that performance threshold is going to continue to increase from year to year. Again, it's 45 points this year. It's finalized at 60 points next year. After that, in program year 2022, that threshold is going to be based on the mean or median of the final scores for all MIPS eligible clinicians in a previous year. This means that we are likely to see the minimum performance threshold in 2022 to be somewhere in the range of 70 to 85 points. So in 2022, participants will need to achieve scores that were previously considered exceptional performance in order to avoid a significant Medicare penalty. So my mantra here is shoot for the moon today so that you don't shoot yourself in the foot later. Don't just go for the minimum. Do the best you can. You want to ensure that during these transition years, you are already scoring in the 70 to 85, make it 70 to 100 points. Because if you're not, in a few years, that's going to be your minimum threshold that you need to achieve. So get good at the program now. Ensure that you're doing really well right now, because what is now exceptional performance is going to be that minimum threshold that you need to overcome to avoid a penalty later. We saw CMS kind of finalize this in the 2020 rule as well. If you know you have bad data, inaccurate, unusable, or it's otherwise compromised, we saw a host of EHR vendor issues out there last year. I think some of those will remain in 2020. If you know that you have submitted bad data because something was wrong with it for whatever reason, let CMS know. They'll take it on a case-by-case basis, and if they determine that, let's say, your final score that they have awarded you was actually awarded based on bad data, you could get some reweighting and potentially a change in your MIPS final score. So certainly, if you've been penalized, you want to do this if you can to see if you can get around that penalty. But CMS demands of you that anytime you have submitted data that you have determined later to be inaccurate or compromised in some way, you need to let CMS know that. All right, we've got a few minutes left. I'm going to get through some of the APM stuff, the different track. So we've stepped away from the MIPS track. We're now looking at the alternative payment model track. So really what we're talking about here is the advanced APMs. The majority of the APMs out there, the different ACOs, the majority of them are still considered MIPS APMs, not advanced APMs. But if you are in an advanced APM, the program changes significantly for you. But again, the vast majority of the ACOs out there are still considered MIPS APMs. So that's where you're kind of bridging the gap between these two main tracks that I talked about right away in the beginning of this deck, where you are in an APM, but there's not enough risk built into it, so it hasn't reached that advanced APM designation. Excuse me. That overall goal of the QPP is to get as many clinicians participating in these advanced APMs as possible, but we're not quite there yet. The vast majority of you are still find yourselves in what are called these MIPS APMs, where you're bridging that gap. You get some fantastic considerations in the MIPS program, but you do still have to participate in the MIPS program. Those advanced APMs, really what it comes down to is having that two-sided risk and having enough two-sided risk built into it to reach that advanced APM status. But if you're in one of the advanced APMs, just note that that is not enough to avoid reporting in MIPS. Your advanced APM also has to achieve something called QP status, or qualifying APM participant status. I've got a hyperlink to a helpful zip file that CMS has issued here to learn more about QP status. If you're in an advanced APM, you're going to want to grab that resource and take a look at it. It is an important consideration. It is becoming more and more important every year to ensure that you have this QP status. We're going to see more and more advanced APMs miss QP status. We definitely saw it happen in 2019. We're going to see it again this year, and most definitely starting next year, QP status is going to be harder and harder to achieve. So QP status, it means that a certain threshold or a percentage of charges from attributed beneficiaries are passing through that ACO's payment methodology. So that means, all these Medicare patients are being attributed to the different ACOs, and it's up to all of the participants in those ACOs to ensure that the patients are only seeking care from within the ACO participation list. If you have too much leakage outside of that ACO, you might miss QP status. QP status is awarded at the APM level, so either all of the clinicians in that ACO get QP status, if it's that advanced APM, or none of them do. So what if that threshold of QP status is not met? So there's a slightly lower level of percentage, and I'll show you what those percentages are on the next slide for QP status. If it's slightly lower, shave off 10% of each one of those thresholds, you'll see on the next slide, and you could be partially qualifying, or a PQP. A PQP has the choice to participate in MIPS or not. If you find yourself a PQP, you could choose to just do nothing, meaning you're not going to receive any of the financial gains of the advanced APM, the 5% lump sum bonus that is a function of that. But you could also opt into the MIPS track as well, and then you would be a full MIPS incentive track provider. And if the APM does not meet that lower PQP threshold either, meaning they're not a QP and you're not a PQP, then the participants in that advanced APM must participate in MIPS. And you'd still be scored under what's called the APM scoring standard. So you find yourself having to participate in as though you were a regular MIPS APM participant. So QP status is very important to keep an eye on. And we've got some increasing thresholds here too. So in 2020, they've got two different ways that they're figuring QP status: the payment amount method and the patient count method. Whichever one is most advantageous is what they're going to use. Next year, this is where things are going to get really interesting. So we're going to see another jump in QP status thresholds. And we're already starting to see some advanced APMs miss these thresholds. And if they're not careful, they're really going to miss come next year as well when these thresholds increase. So if you are a QP in advanced APM, you are exempt from MIPS reporting, and you are going to earn a 5% lump sum bonus based off your Medicare reimbursement. So it kind of removes you from adjusting your Medicare reimbursement rate, and instead you get what's called the 5% lump sum bonus. You also get some higher reimbursement rate updates in a few years. And again, you are exempt from MIPS reporting. But again, you have to be a QP in that advanced APM to avoid that MIPS reporting. MIPS APMs, this is where we see the majority of clinicians in these ACOs still falling. This is where you're bridging that gap. You don't get the advanced APM benefits, so you have to participate in MIPS, but you're participating at the group level. And we see most of these ACOs performing exceptionally well in the MIPS track because they're sort of strength in numbers, right? The rising tide raises all boats. So we're seeing most of these ACOs do a fantastic job. They're really earning fantastic MIPS scores for their clinicians. You don't qualify for that 5% advanced APM bonus, and you're not eligible for those higher baseline annual updates. But again, that's strength in numbers. So most of these MIPS APM participants are doing exceptionally well in the MIPS track. You are, however, shifted to scoring the weights change a little bit to something called the APM scoring standard for those MIPS APMs. And again, for any advanced APM folks that don't get QP status or partial QP status, you'll find this is the weight. So really it just shifts that cost category a little bit. It goes down to 0. Quality jumps up a little bit to 50%. Improvement activities gets an additional 5%. So that's up to 20. And promoting interoperability also gets an additional 5% there. This is an interesting change for this year. I think this is going to play out really well for those APMs, for those MIPS APM participants. Up to this point, your quality category score came just from the CMS web interface quality reporting that your ACO is doing on your behalf. There is a new stipulation built in for 2020 that those clinicians at the TIN level could also submit their own quality measures, much like a regular MIPS participant. And then again, CMS is going to look at the quality data that is being reported by the ACO, and then they're also going to look at the quality data that is coming straight from the practice, much like a regular MIPS participant. And they're going to award that TIN or that clinician with the better of the two. So I think this is going to help those ACOs get an even better quality category score, because those CMS web interface measures that the ACO is using are not particularly well suited to the specialties. And a lot of these ACOs have specialty clinicians as well. So these specialty clinicians could submit their own quality category data as well. And then CMS is going to look at those two data sets and use the data that is most advantageous to roll up to the ACO. So it doesn't mean that you're going to get your own separate quality score that's separate from the ACO. It's a different data set that CMS is going to use to build the overall ACO quality category score. So if you can, you might consider, even if you're in that ACO, you might submit your own quality category data as well. And you could really help your ACO out that way by getting better data to them. All right, as we wrap up, and I see I'm gone a few minutes over, as I usually do, I do want to make you aware that there is free help if you are in a small practice, and I know most of you are. If you are in one of those small practices, we are here and being funded to help you for free. That's what brings me to you today. We are helping clinicians through our QPP Resource Center. I've got the link right down here. If you have not already joined up with us through the QPP Resource Center, I highly encourage that you do. It's going to give you access to folks like myself. I've got a whole bunch of my colleagues that are also subject matter experts and are ready and waiting to help you with every question you can possibly throw at us. We can provide a lot of guidance to you here. And so if you are struggling in this program, I know most of you are, it's very, very confusing, let us help you. Link up with us, join up with our QPP Resource Center. Not only is it going to give you access to a bunch of my very helpful and knowledgeable colleagues, it's going to give you access to something called MIPScast. We have developed our own scoring platform where we have mimicked. We know exactly how CMS is going to score your data. So we've created this sandbox called MIPScast, where you can give us your data and we're going to tell you exactly what that means. This is an essential tool when it comes to quality category, where as you've picked up on through my slides, the quality category is insanely confusing. It's hard to know what the best measures are and what the best submission method is, and the benchmarks are confusing. MIPSCAS strips all that confusion away. In what would take you hours and hours and hours to try and figure out on your own, MIPSCAS does in a second. If you can give us your quality data, MIPSCAS is going to score it for you and tell you exactly what your best measures are, what that best reporting method is. We can work with you to refine that data, and we can now also submit it on your behalf. MIPSCAS is a qualified CMS qualified registry, or QR, which means we are now a conduit to submit your MIPSCAS, or to submit your data for you. So we can work with you all year long to ensure that you've got the best possible data, that you're getting the best score you can. We'll kind of flag what your best data set is, and then we will submit it to CMS on your behalf if you would like. You do not have to use that portion of MIPSCAS. You can just use it as a sandbox to kind of play with your own data to see what's best. But if you would like us to submit it on your behalf, we can also do that. And if you are a small practice, it is free. For anyone else in the large practices, we can still help you, certainly through the Resource Center and through MIPSCAS and through reporting that data for you, but there might be a small fee attached to that. All right, one last thing is if you would be so kind as to, oh, there's my poll. I'm going to submit a poll here for you. If you would please do me the favor of telling me how I did today. CMS requires us to do this as part of our funding. They want to make sure that we are out here spending their money well and providing you the service you need to get through this program. So they ask us to poll everybody, and then we pass this data on to CMS. So if you would be so kind, I will leave this open for just another moment. Thank you so much. Hopefully I have given you some good information, some good actionable information that helps you through the program. All right, I'm going to close that out. And my last slide for you is our contact information. We are here to help you. We know this is insanely confusing. There's so many different facets. It is very hard to figure out how your particular unique practice situation kind of morphs and how to participate in this program. We've got all this figured out for you. So anything we can do to assist you, please do not hesitate to reach out. Again, CMS is funding us to be out here helping you. If you are a small practice, everything that we have to offer is free. So there's no reason not to reach out to us. Link up to us through the QPP Resource Center. We've got our general email box there as well that my colleagues are keeping an eye on. Also, feel free to hit me up. I've got my email address there. We've got my desk phone right there as well. If you've got any questions, comments, concerns going forward, do not hesitate to reach out to us. We'd love to help you through this. I've only gotten one question, which I know there are a lot of questions out there. So hit me up with questions. I've gone over as I usually do, and I apologize for that. But thank you so much for sticking with me today. The one question that I did get, I will answer offline. But again, if there's anything I can help with, do not hesitate to reach out. I love helping you, and I want to make sure you have exactly what you need to perform well in this program this year. With that, I'm going to sign off for today. Thank you so much for joining me. As the year goes on and we learn more about the changes that COVID-19 is going to cause with this, I will have some more firm answers for you on how it's going to morph your 2020 participation. So certainly tune back in later as we learn more from CMS. Thank you so much for joining me today. Have a good one.